Welcome to News Today, a PodNu service. Today is Saturday, March 26, 2022, Central European Time. There is a study that says that half of all women will have at least one false positive mammogram. Over a decade of annual screening with digital breast tomosynthesis, 3D mammography. In women who get screened every other year, the risk of false positive results after 10 years is much lower than in women who get screened once a year. There is no cancer in the breast when a mammogram is flagged as abnormal, but there is no cancer. Today, the study was published in JAMA Network Open, which is part of the JAMA network. People who have 3D mammography for breast cancer screening can get a false positive result less often than people who have digital, 2D mammography. Screening every other year and not having dense breasts were also more likely to reduce the risk of false positives. Another thing to note, older women were also a lot less likely to get a false positive. The screening technology did not have the largest impact on reducing false positives, said Michael Bissell, epidemiologist in the UC Davis Department of Public Health Sciences and co-first author of the study. Findings from our study highlight the importance of patient-provider discussions around personalized health. It is important to consider a patient's preferences and risk factors when deciding on screening interval and modality. Women in the U.S. die from breast cancer at a higher rate than men do from other types of cancer. Early detection through screening mammography is an important way to cut the risk of advanced breast cancer and death from it. When a screening mammogram shows that the person has breast cancer, but they don't, it's called a false positive. When abnormalities are found on a mammogram, the patient is called back in for more imaging and tests. It's called a false positive if a patient is found to have cancer at the end of the diagnostic evaluation and for 1 year after she is called back. Despite the important benefit of screening mammography in reducing breast cancer mortality, it can lead to extra imaging and biopsy procedures, financial and opportunity costs, and patient anxiety, said Diana Miglioretti, professor and division chief of biostatistics at the UC Davis Department of Public Health Sciences, UC Davis Comprehensive Cancer Center researcher and senior author of the study. False positive results happen all the time. Around 13% of 2D screening mammograms are called back for more workup, but only 4.4% of those calls, or 0.5% of all calls, end in a cancer diagnosis. To detect breast cancer early, we need to be careful and investigate any potentially abnormal findings. So, women should not be worried if recalled for additional imaging or biopsy. The vast majority of these results are found to be benign, said Thao Nguyen Ho, radiologist at the University Medical Center in Ho Chi Minh, Vietnam, research fellow at UC Davis School of Medicine and co-first author on the study. The Breast Cancer Surveillance Consortium had 3 million screening mammograms done for 903,495 women between the ages of 40 and 79. The data was analyzed by the researchers. The screenings took place between 2005 and 2018 at 126 radiology facilities. The study looked at how often people get checked, how old they were, and how dense their breasts were. It looked at how likely it was that a woman would get at least one false positive recall over 10 years of annual or biennial, every other year, screenings. It also looked at the risk of a false positive that led to a recommendation to repeat imaging in 6 months, short interval follow-up, and a biopsy recommendation. The study found that the chance of getting a false positive recall over a 10-year period was a little less with 3D digital mammography than with 2D digital mammography. There were less false positives when 3D mammography was used instead of 2D. This was especially true for women who didn't have dense breasts or who had annual checks for breast cancer. Over 10 years of annual tomosynthesis screening, 50% of women will have at least one false positive recall. 17% will have a false positive short interval follow-up recommendation, and 11% will have a false positive biopsy recommendation. 56% of women who had 2D digital mammograms had false positives, 18% had short-term follow-ups, and 12% had a biopsy. False positive results were much lower for older women and women with very dense breasts, no matter what kind of screening they did. The study also looked at the 10-year risks of having annual or biennial screenings. It found that having a mammogram every other year had a much lower chance of at least one false positive result than having one every year for 10 years. This was true for both 3D and 2D mammography. We were surprised that the newer 3D technology in breast cancer screening does not substantially reduce the risk of having a false positive result after 10 years of screening. However, chances of false positives are much lower with repeated biennial versus annual screening, said Ho. 17% of women who get 3D mammograms every year are thought to have at least one false positive over the next 10 years, compared to just 10% of women who get them every 2 years. False positive benign biopsy recommendations are thought to happen in 11% of women who get annual 3D mammograms, but only 7% of women who get them every 2 years. After 10 years of annual mammograms, the risk of getting a false positive result was lower in 3D than in 2D. This was true for all outcomes. 3D mammography had a lower risk of false positive recalls when people were screened every 2 years. In terms of short follow-up or biopsy recommendations, there was no difference between groups. This is what people said. They are Carla Kurlikowsk, Jeffrey A. Tice, Rebecca A. Hubbard, Brian L. Sprague, Christoph I. Ali, Anna N. A. Tossin, and Anna N. A. Tossin are the other authors of this study, as well. With the UC Davis Center for Healthcare Policy and Research and Kaiser Permanente Washington Health Research, Miglioretti is also a member of their research team. This project was made possible by the National Cancer Institute, P01CA154292, U54CA163303, and other grants. The Agency for Healthcare Quality also helped. The University of Vermont Cancer Center received funds from the Lake Champlain Cancer Research Organization, which gave grant number 032800 to the project. The Patient-Centered Outcomes Research Institute, PORI, also helped PCS 1504-30370. It was helped by the UC Davis Comprehensive Cancer Center, the Placer County Breast Cancer Foundation, and the UC Davis Clinical and Translational Science Center.